So welcome back, everybody. Sorry for burbling on during the intermission there. It's great to have you back. So this is a little bit of a cheat, as you've gathered, because I am going to talk about the future of NNAP, but I'm really also going to talk about some of the results as well. It'll be even better if I can make my slides advance. There we go. So what I'm going to try and talk about is some updates on how we're working. I'm going to try and show some new ways of presenting the data. And I'm going to show something about putting the measures together in spline plots. And then we'll hopefully be able to have a good free-flowing discussion, for which send your questions to Oliver Rackham on the chat in the usual time-honored Zoom way. So here are some operational updates. The collaborators meeting, we postponed. It was going to be a face-to-face meeting in November last year, and we've put that off until no, not in November, in March, and we've put that off until November next year, by which time we're all hoping to be fully immunized. And we'll be holding that in London. And who knows, we might even have a glass of wine afterwards. So clearly, like everybody else, we've moved all of our meetings online, and we've had the usual learning curve associated with that. It's a strange thing, but I hope you're getting used to it as we're trying to. The 2020 data, we're really going to plan to try to deliver the same methodology, but we understand the results might not be the same because of the impacts of COVID on the way we work. But we're really going to try to measure things in the same way and not give ourselves excuses. But we know that not everything will be quite the same in terms of what we achieve. Hopefully it'll be continuing improvement, but perhaps not all in the same way. So we have identified some outliers in the 2019 data, and some units have been written to. Ask me how I know. And neonatal, and there are slightly less alarm level outliers than there were than there were last year. I'm not sure that that's an enormously big difference. We plan for the 2020 data to use the same methodology. Well, as ever, we welcome your comments and participants about that. But clearly, the significance that's attached to what we measure will be different for 2020 data year. We're continuing to provide results to support GIRF, the Getting It Right First Time program, CQC, National Clinical Advisory Bureau, is that, and a whole variety of other bodies that are interested in the data that we work with. We're continuing to link with MatNeoSIP and BAPM, as we've just been hearing about. And really, it's a bit pompous, but I like to call that unifying the measurement conversation. So hopefully we're not all trying to measure things with slightly different yardsticks. Thinking about the quarterly reporting, that's ongoing. As you know, for the 2020 data, you should have had your Q3 recently. And we could answer questions about that in due course. And we're continuing to develop measures. Well, we're not developing any new measures, but we want to keep communicating with you. We're always open to new measure ideas, but we've got quite a few. So I want to talk about some clinical reporting updates. Firstly, I want to talk about the preterm brain injury measure. So of the outcomes I showed you at the very beginning, I mentioned the IVH and PVL as I think what it was abbreviated to in the slide. We've been working with an expert group for well over a year to describe an outcome measure of what you might call IVH stroke PVL. This has been to an expert group, and we had a sort of external expert consultation group. We've been back and forth to the methodology and dataset group and the NNAP project board with respect to that. We've implemented the measure on the BadgerNet system. It's got wide support, so we're very excited to be implementing this for the 2021 data year. The measure itself, I'm not going to go over in great detail, but it only applies to babies that are less than 32 weeks. And we're trying to evaluate IVH, in which we include hemorrhagic parenchymal infarction, or HPI if you like, post-hemorrhagic ventricular dilatation, and cystic PVL. The definitions for all of those measures are already embedded in Badger and have been for some weeks. The data will, of course, require validation because depending on how you clean your data already. In my neonatal unit, I know that I need to go and check whether that's been entered correctly. And so I'll be doing that at the end of the year. Well, I'll probably do it as the year goes by. To make sure that we're describing any abnormalities that we do see correctly. So I've got some new formats and it's barely new analysis, but I'll try to take you through those in the following categories. And I'm going to finish up by discussing the mortality results and the use of matching in respect to that. So I didn't talk about the results of the parental attendance at consultant ward rounds in the first talk. Above is a graphic that I stole earlier from NNAP online. It'll be very difficult to read unless you get very close to the screen. That's Bradford. So in the top row, you see light blue for the proportion of babies whose parents attended at least one ward round at any time during the baby's stay. And we got about just over 80% in that. And that compares reasonably to the comparators that are below. But there's a pretty strong feeling from parent representatives that that's not really good enough. Just being able to attend a single consultant ward round and that count as a pass for an individual baby doesn't really feel very descriptive. And so below what you can see is the data for Bradford, looking at, in this case, we get about 87% in the period analysed here. But what we thought would be helpful would be to present alongside that measure the proportion of days where a consultant ward round occurred and a parent was present. And that's a much lower proportion. It's about 1 in 5 rather than 4 out of 5. And so we thought that would be a useful thing to present alongside that measure. It's a bit more descriptive for those units like my own that are trying to be on a journey to making parents involved in ward rounds as part of parental partnership in care. So that's the thing we're planning to do differently, and that's already come out in the Q3 report. So maternal breast milk feeding, we've got some measures of that, as you know, and the measures are: does a baby who's born at less than 32 weeks gestational age receive any of their own mother's milk on the 14th day of life? And does a baby born at less than 32 weeks receive any of the mother's own milk at discharge? So I might skip forward to breast milk feeding at discharge. As a community, we're not great at this. There hasn't been much change over time. It's about 6 out of 10. There's not much change since 2013. And we all think that that's concerning, and it's difficult to know what to do about it. That's part of the reason for introducing the breast milk measure at 14 days. But actually, we thought that it would be more helpful to look at, to try to present graphical representations. So I should have checked whether people can see my mouse. Jess, I don't know if you're on mute. Can you see my mouse or not? It's just
yes, I can.
You can see the mouse, fantastic. Okay, so hopefully that means everyone out there can see the mouse. So if we just were to take this bottom right-hand panel on the slide I'm now showing, this graph is describing all the babies of less than 32 weeks over 90 days on the horizontal axis this is in a given neonatal network. And you can see in this slide that the majority of babies fall into this darker green, so are receiving at least some breast milk early on, and even by 3 weeks of age are receiving some breast milk. The light grey underneath is babies who receive only formula milk on a given day. And you can see that is it's larger in the northern region than it is in the panel above, which represents the network London, North Central and North East. And then the light green is babies who've been discharged, who were receiving some breast milk on their last day in hospital. And the light grey is babies who were discharged receiving only formula milk on their last day in hospital. You can see that gradually gets wider. So in general, at a network level, I think you probably agree that the shape of these is all quite similar. However, if you compare northern, so London, North Central and East, I think you would find it easy to be convinced that in the northern region, where I did so much of my training, lived for so much of my life, the proportion of babies who are either inpatients receiving breast milk or have been discharged, having been receiving breast milk on the day of discharge, is considerably less than half, whereas in London, North Central and East, it's considerably more than half. And so in that regard, that would appear to be success for London, North Central and North East. We hope that these figures might be useful to neonatal units and perhaps also networks. And so these figures will be available on the NNAP online website, but I believe they're not yet available because we're just fine-tuning. So apologies for that. There's been a slight communication error, but they will be there very shortly, and we will email out when they're available. So we hope they'll be useful. We really welcome feedback about that. A lot of work's gone into trying to get this right and get it agreed. Hopefully it will be useful. So as a take home for the 14-day breast milk measure, good news, 8 out of 10 babies get some of the mother's own milk at 14 days of age, but there's quite a variation between 88, so 3 out of 4 versus plays 9 out of 10. So that doesn't reflect very well on all of the neonatal networks. Worryingly, from the perspective of the key findings group, neonatal intensive care units do not, on average, have higher mother's own milk use than local neonatal units and special care units. And this is felt to be a worry, given that neonatal intensive care units are looking after the babies who've got most to gain. The higher risk babies have got the most to gain from being breast milk exposed. There is a wide variation in mother's own milk units at unit level between 68 and 92%, but only 2 neonatal intensive units can be identified as low outliers for what that's worth. So hopefully looking at your own figures will be helpful in identifying where in the patient journey it is that you're successful and where that you want to try to influence change. For my own neonatal unit, we do well at starting babies on breast milk, but we're not as successful as we would like at keeping them on breast milk as the weeks go by. So there are, as you'd expect, some recommendations around that. I'm not going to go through these in great detail, but these are designed to be helpful. They're very carefully thought about, and we hope they'll be useful to you. So nurse staffing, that's never a thing to worry about, is it? As you know, neonatal NNAP has 3 measures of nurse staffing. In particular, what proportion of nursing shifts are numerically staffed according to the guidelines, and what proportion of shifts have sufficient qualified in speciality according to the guidelines. And there's a third measure: how many additional nursing shifts would you need to have worked? In general, people have tended to want to say to us that neonatal intensive care units have the problem and that other units don't have the problem. I hope this figure makes clear that that's not true. So along the horizontal axis, we have the size of the neonatal unit, and that's based on the amount of babies that they look after. This is how many nursing shifts would be required to look after the babies within that neonatal unit if it was staffed appropriately for every shift. And then on the vertical axis, we have the proportion for each unit of shifts that are staffed according to the guidelines. I hope that you would be convinced that for units of between 10 and 15,000 annual workload, that there's a wide variety amongst NICUs, that some NICUs are apparently staffed adequately almost all the time, and there are neonatal intensive care units that are apparently staffed inadequately, adequately only about a third of the time. So assuming that this hospital is an outlier, didn't put the data in, which is what we believe. There is a strong sense, there's a little bit of relationship, but in general, special care units have slightly better staffing, and there's a structural size reason for that. But in general, it's not just about the size of the units. Small units have problematic staffing. Large units have relatively good staffing. The take home from this is that neonatal intensive care, that neonatal units have staffing that is significantly below recommended levels. Only 2/3 of shifts are numerically staffed to the recommendations. That's a little bit better than 2018, but only a little bit better, and is described by our key findings group as a serious cause for concern. And I don't mean that in a joking fashion, that the use of the word serious is intended to add real emphasis. NICUs do experience the highest proportion of shifts, not staff recommendations, but and the NICUs that will have the patients who are the most unwell, so that is clearly a concern. And if anything, the qualified and speciality adherence, which I haven't talked about in any detail, appears to be worsening within the intensive gains. So it's not great. So recommendations. NNAP says that the Departments of Health in England, Scotland and Wales should ensure that sufficient resources are available for the education and employment of suitably trained professionals to meet the guidelines. And that universities and Health Education England, or equivalent bodies in the developed nations, should consider revising, renewing and standardizing the models of specialist neonatal nursing education. And that's because we hope that staffing will improve and the proportion of specialist nurses will improve. But that will only be a meaningful change if everybody understands what specialist nursing qualifications actually means. So there's work to do there for the system. It's felt that neonatal units and networks should prioritize their data quality assurance, because there's clearly a very small number of units where the data is not right. It's a very small number of units, but there are some. We think that units and networks should monitor adherence to this and develop action plans. And I imagine that many neonatal units, certainly my own, has an action plan to address any deficits in their staffing and skill mix. So that's nurse staffing. That's not a small thing. I've talked about lots of different measures, and you'll be sick to death of listening to me. I've only got one more measure to go, but before that, we want to show you something that we call spine plots. Now, this is shamelessly stolen from another audit, but we hope it might be helpful to you. What this does, and I'm showing you here Yorkshire and Humber, but mostly because it was to hand, but also because people don't like me publicizing their data. I'm showing you here Yorkshire and the Humber. And the black midline here is the national rate. And for this particular measure, antenatal steroids, you can see here the black dot representing Yorkshire and Humber's position shows that Yorkshire and Humber are good at antenatal steroids, if you like. The grey bar represents the expected range, if you like. There is no expected range for nurse staffing for statistical reasons, but hopefully this will give colleagues in the Yorkshire and Humber a bit of a feel for what it is like in their neonatal network. And we felt that by comparing networks that might be useful. So that networks might get a bit of a feel for where they're strong, and Thames Valley and the Wessex are strong at everything, nearly everything. And give networks an idea of their sort of priority areas for improvement, and where they're strong, where they're not so strong. And these are available in the report, which you can download today. I know I've checked. There are also unit level spine plots. These look just marginally different. And you can bring up, I'm showing you Bradford's for obvious reasons, not because we're proud of all the results. But here we see, you could bring those up, and I could put up another unit next to this. I can put up to 4 units in one panel. And that will show us where we're relatively strong and where our areas of improvement are. And these are not a surprise to us, and we have action plans to deal with, to be honest, all of those. I'm pleased to say. So we hope this is useful to you. We welcome feedback about it. We hope that you might want to compare yourselves to units that you want to be like, or units that you don't want to be like, and see where your strengths and weaknesses are. So finally, I'm going to talk about mortality, and then I'm going to get off and do some questions. This is the audit measure, as you know, is what is the mortality? Does a baby born at less than 32 weeks gestation age die before discharge home, or 44 weeks postmenstrual age, whichever occurs sooner? And of course, some of the babies die. So here is the caterpillar plot for neonatal networks. And this shows for babies of less than 32 weeks that about 1 in 20, just over 5%. It's about 1 in 20 die. You can see that there is some variation by neonatal network. There are a couple of neonatal networks where the uncertainty around their mortality is well below the national average. And at the other end of the plot, there are neonatal networks whose dots are above the average, and the confidence intervals you can interpret for yourself. So this is pretty worrying. It looks as though crude mortality varies from just over about 4.5% to around 9%. So that's almost a doubling, isn't it? Well, it is a doubling. So this is very concerning. We've seen this before in the previous years, and we know that it's a matter of concern. That when we presented this data previously, we did a different form of risk adjustment. We've changed the form of risk adjustment to the so-called matching analysis, as I showed you with the BPD data. So just to repeat, this asks the question, how would the babies from, say, my own neonatal network have got on based on their characteristics if they'd been looked after in the whole country? And then it takes the difference between the measured mortality and the mortality that statistically would have occurred had they been looked after all over the country, and you generate a treatment effect. And positive is not good. So we can see here that the networks are in pretty much the same order. If you look in detail in the report, there are some neonatal networks that are low outliers that have treatment effect that is well below zero, and where the confidence interval, the measurement of uncertainty, doesn't cross zero. So that tells us that being looked after in those neonatal networks appears to be a real advantage to their babies. So in effect, we all want to be like it is in London, North Central and North East and East of England. There are other neonatal networks. There's another neonatal network, which is a high outlier, has high outlying mortality. And these are just facts, they're neutral. We hope that this is useful information to neonatal networks. You can do the same analysis for babies of less than 28 weeks. So then on the vertical axis, the rate of mortality changes. So it goes from about 5% to about 15%, about 1 in 7. But you see exactly, or not exactly, but very similar gradient in mortality. And again, the mortality is double in some neonatal networks what it is in others. You can look at a treatment effect and you see the same phenomenon that I was describing previously. So that this is a concern. And this should prompt neonatal networks to engage in this issue. And we've thought carefully about what they might do. The suggestion is that neonatal networks and their constituent neonatal units should, following a review of their local mortality results, take action to consider whether a review of their network structure, their flows, their clinical guidelines, or their staffing might be helpful. And to consider whether a QI approach to the appropriate delivery of evidence-based strategies like timely antenatal steroids, deferred cord clamping, avoiding hypothermia, and the early management of respiratory disease, whether a QI approach to those evidence-based strategies will be helpful. And to make sure, so networks and units should be making sure that locally delivered, externally supported multidisciplinary death reviews, including data from PMRT, informs their network governance and clinical practice, unit clinical practice. And further, the recommendations consensus group felt that the patient safety team and NHS improvement and equivalent bodies in the developed nations could and should facilitate national dissemination of learning, because it's no good having these lessons if they're not shared. So national dissemination of learning from mortality reviews. So that's me, I'm nearly off. The NNAP has been granted an extension year from April 2021 to 2022. That's a COVID phenomenon. We want to, we are going to consult with HQIP and with you all on whether it would be helpful or possible or helpful to try to publish some of the data that I've shown you earlier in the year. It will probably still take as long as it has done this year to produce a report with the key findings, recommendations, outlier analysis, and all of that. But the suggestion is that we might be able to separate some of the report, some of the data publication from the report publication, although there's much to clarify about that. And there'll be further changes in the way that we work in the coming year, but we'll try to keep you informed of those. So with that, I'm going to get off and stop sharing so that I can see people.